The Thinking Practitioner podcast is supported by ABMP, the Associated Bodywork and Massage Professionals. ABMP membership gives professional practitioners like you a package including individual liability insurance, free continuing education, and quick reference apps, online scheduling, and payments with Pocket Suite, and much more.
ABMP's CE courses, podcast, and Massage and Bodywork magazine always feature expert voices and new perspectives in the profession, including Whitney Lowe. Hi, Whitney.
Howdy, sir.
And myself, Til Luchau. Thinking Practitioner listeners can save on joining ABMP at abmp.com/thinking. Hey, Whitney, you do write for Massage and Bodywork, and we're going to talk about one of your articles today. How are things going?
Going very well. I've been off for a couple of weeks. I enjoyed listening to you do some episodes with some other great folks around here. And I took some time off this summer and was doing some roaming around in the Canadian Rockies, and very good to be back here behind the microphone again with you. So good to see you again. And yourself?
Likewise, good. Just back from roaming also. I took my microphone with me. So I was broadcasting from the road a little bit there. I did that one with Werner last time, and we missed having you there, but it was a lot of fun. Mm-hmm. It's also great to be back. And then you and I are going to Montreal. I'm going tomorrow.
Yep.
For the Fascia Research Congress, and we'll both be there next week. So that'll be great to have that time together.
Yeah, we may end up doing an in-person recording or something like that, which would be a first for us.
Yeah, we'll do something. We're going to do something around that because it's, you realize that I have only met you briefly twice in person.
I do realize that, and I can't even remember when. I remember you said there was sometimes, and I can't even remember when it was, but it was like a decade or more ago.
Conventions. Yeah, that's right. These were like at AMTA conventions or something like that. Yeah. Just came by and said hi to you at your booth. Mm-hmm. So no, we'll actually get to meet in person.
Yeah.
And I'm smaller than I look on camera.
So am I. So we'll have that in common.
Awesome.
Yeah. I was doing this podcast with Allison Denny a couple months ago and telling her this story. When I first started teaching, I really had to work at knowing my stuff really inside and out, because not only was I a small person, but I look a whole lot younger than I am. And when I started teaching, I was in my late 20s, and I looked like I was 15. So I have always had to use that as a means of compensating for the physical appearance. So, and it was funny a lot too when I used to teach, with Benny, and he's just this big magnanimous presence, in the room, and big tall guy and everything. So it's like two very different perspectives there.
That's great.
Yeah.
Yeah. We, like I said, it's going to be great to meet you.
Yeah.
And your stuff. So that's a pleasure as well.
Yeah. So speaking of stuff, what are we doing today? What are we talking about today?
Well, I wanted to talk with you about the sacroiliac joints and about the bones that connect the ilia, the big bones of the pelvis, innominate bones, etc. But not only do I love talking about that part of the body and those joints, even though we already discussed it in episode 3, but it's like there's never enough to say. But you just published a cool article about that in Massage and Bodywork. I got it right here. Current concepts in sacroiliac joint dysfunction. I wanted to talk about that some. And then I am teaching one of my principles courses where we meet for 4 live online lectures about the ilion SI joints, and that starts a free intro on September 28th. I'll give more information at the end of the show. September 28th, 2000, what year is this? 22.
Mm-hmm. And
then the lectures start October 5th. But if you're catching the episode later, they're going to be by recording.
Yeah. Okay.
And then also, I'm looking forward to this topic. Right here at the beginning, I wanted to give a shout out to Jeff Bramall and Bori Surani for they did like an in-depth kind of secret shopper review of my last principles class. I didn't even know that Jeff was in the class. He took the class, and then he did a whole podcast episode about it that I found by accident.
Oh, wow. Huh.
Yeah, I was listening to this nervously. He's like, what's this guy going to say about this whole course? Because he advertised a review of advanced trainings in Til Luchau. I was like, okay, here we go. But their podcast is called Hands at the Table. We'll put a link in the show notes here as well. And I won't do any kind of plot spoilers. You're going to have to hear how they reviewed our class.
Yeah, well, I'll have to go listen to that podcast too. So
yeah, I was on the edge of my seat. Anyway, they did a good job of being really analytical and thorough about it.
Yeah.
So let's do that for the pelvis. Let's be analytical and thorough as well as experiential, because I want to move a little bit. But what if we start with the anatomy of the sacroiliac joints? Whitney, what do you think? You want to start there?
That sounds like a good starting place. Yeah. So I was going to talk a little bit about some key concepts of anatomy and mechanics related to this. And we are doing something a little bit different today. For those who've been listeners for a while, we are going to, this show is going to appear in video as well. That's the plan. And so I'm going to put some stuff on the screen. So those of you who are listening to the audio version, we will make reference to some things that we're showing on the screen. We'll try to describe those as much as possible, but there will also be links to the video version on our respective sites, and we'll put that in the show notes and talk about that at the end as well. Yeah. So that is the plan. So without further ado, let's take a look in there and see what we're talking about here at the sacroiliac joints. So first thing is we want to take a sort of a reminder of where we are. We are looking at the place where the sacrum meets the ilium on each side. And there is of course, left and right sacroiliac joints. Couple things from bony architecture that I wanted to call attention to. This particular image does not necessarily show this really thoroughly. And I think, Til, you've got some other images that will show this more clearly. But these joints are unlike many of the other joints in the body, which are smooth gliding surfaces, in that there's a very rough and irregular contact surface here on the side of the sacrum, and a similar rough and irregular contact surface on the ilium, which sort of meets each other and interlocks. So it's this interlocking sort of mechanics of the bone itself, not to mention all the other soft tissue structures around there. But that's a big key part of making stability in the sacroiliac joint, is the sort of interlocking alignment. Consequently, when that alignment is somewhat off, and we'll talk about what might cause it to be off in other situations, this may cause some of the other significant pain problems when those bony contours are not aligning with each other. It's pretty easy to see how that might occur. And I'm going to mention some other things a little bit later on too, about the high percentage of nociceptors that are inside the sacroiliac joint, and many of the other connective tissue structures around here that are highly and richly innervated, that play a role in a lot of those pain complaints that we see. So a couple other key things here too that I want to highlight with anatomical structures, in particular, the ligamentous structures around here. So you have the binding anterior sacroiliac ligaments on the front side, and then there are also pretty significant binding on the back side here. So these ligaments hold this joint relatively firmly, because it's a very important process of trying to transmit the body weight from the central core axis of the skeleton into the appendicular skeleton, and that comes across, of course, through the two sides of the sacroiliac joints here. So transmitting that weight from each side. And let's just briefly kind of illustrate that, as that weight's coming down here is distributed across these joints on each side, going directly across the sacroiliac joints. So these ligaments are holding those that sacrum in position. Another image up here, just let me show this real quickly to highlight some of these major structures here.
Hey, before you get out of that one, can we go? Is it too late to go back to that?
Nope, right there.
That's so on the screen there for the listeners, we have a view of the back side of the body with Whitney's really cool software. And he's showing these massive ligaments around the SI joints. And he's drawn lines that show the spine's weight transmission splitting there at the sacrum and being transmitted into each side of the pelvis, each left and right ilium. Did I get that right, Whitney?
Yes, sir. Absolutely.
And then there's strong ligaments all around those joints. And you're talking about the role those ligaments have in that weight transmission. We can really see that wedge-shaped arrangement of the sacrum there. It's like a downward pointing wedge, or the arrowhead on the bottom of the spine. So you can imagine that weight pushing that sacrum down between those bones and wanting to pull them apart, but the ligaments resisting that and loading from that weight-bearing function and really snugging that joint up tight.
One of my anatomy instructors in massage school spoke about this, and the similarity to the architectural design of a keystone in a bridge, which the keystone is that very top stone that's wedged like this in there that holds the arc across, like a whole bridge across the whole pelvis like that. And then that wedge comes in there and holds those two things and binding them together and distributes the weight across each side, hopefully equally. But that's something that we're going to also look into here, is that sometimes that doesn't happen equally. So
hopefully, left and right sides of the arch. And there is some evidence. I'm going to go back and talk about alignment when you're done with your part. Yeah. But there's also evidence that, the equally thing is, at least in terms of stiffness, is an important factor.
Yeah. Yeah. So just take another quick look here at listing several of these other stabilizing ligaments in addition to the ones that we looked at. Up here from the transverse process of L5 over across to the ilium is the iliolumbar ligament.
This is like between the lumbar vertebrae and the top, the iliac crest, almost in the backside of that.
Exactly, yeah. And while that doesn't necessarily span directly between the sacrum and the ilium, because there's such a firm connection between L5 and the sacrum, the iliolumbar ligament, which is coming in and attaching to the side of the transverse process of L5, creates a lot of, or does certainly aid in stability with the sacroiliac joint spanning right across it there. This is another key one down here, the sacrotuberous ligament, which we see spanning from the sacrum down to the ischial tuberosity. So again, most ligaments tell you where they're going and what they connect by their name. So this is from the sacrum to the ischial tuberosity, big sacrotuberous ligament. And
nice. So it's like if that sacrum's like an arrowhead, that goes from the point of the arrowhead at a perpendicular angle diagonally out to the pelvis. So it's like the lower end of that wedge-shaped sacrum. It's being held in by those big sacrotuberous ligaments.
Yeah. And, again, in anatomy books, these structures are pictured and shown as they are here as sort of isolated structures, but we'll talk a little bit more later on too about the fact that they really aren't isolated structures. And in fact, there's a lot of fascial continuities from lower extremity muscles directly into that sacrotuberous ligament. So tension, for example, in hamstring muscles can easily be transmitted through the sacrotuberous ligament to the sacrum itself. So
there's lots of tissues around them, in spite of what we see in the anatomy books, that are part of that weight transmission or tension function as well.
Yeah, absolutely. One other one here we don't hear about quite as often, but also very important, is the sacrospinous ligament, and it is going from the tip end of the sacrum over to the ischial spine. This is a little bony projection here on the side of the ischium, the ischial spine. That is also one of the other major stabilizing ligaments. You can see it here in relation to the sacrotuberous ligament on the other side. So it is deep to that sacrotuberous ligament.
So for our listeners, that would be deep to or in front of, and it's running like almost perpendicular to the floor in a horizontal plane, just straight out to the side of the pelvis, while those big sacrotuberous ligaments are running at an angle.
Yeah, exactly. And we also pay a good bit of attention to that particular ligament. It is one that doesn't get talked about a lot, but is pretty relevant for some of the major nerve entrapment problems with the sciatic nerve getting squeezed against that sacrospinous ligament in
sciatic nerve, pudendal nerve.
Yeah. So
saddle pain.
Those are certainly important there. So the other thing I mentioned a moment ago, just of very key importance here, because the sacroiliac joint has so many ligamentous structures associated with it and other soft tissues and connective tissues associated with attempting to maintain the stability in this area. There are a lot of nociceptors in here, which means a lot of sensory receptors that may be reporting pain in a number of different circumstances. But one of the big challenges, and we'll talk some more about this with sacroiliac joint problems, is those, it's sometimes difficult to determine, are these structures the victim or are they the culprit? They can be the cause of some pain sensations in many cases, or sometimes they may get strained or irritated as the result of some other kind of mechanical loading on them, and when they're the victim. So that's a tough one to figure out sometimes in terms of what's actually happening in there.
Yeah, we talked about that some in episode 3 as well.
Yeah,
the kind of chicken and egg problem.
Yeah.
In the end, it's like, what can we do to help? So I want to get to that as well.
Yeah, good. So that's kind of a basic sort of rundown of some key structural factors with that SI joint.
Nice.
Yeah.
Nice. That's it?
Well, I just wanted to stop there with some basic stuff. We can go into some of the mechanics and mechanical things.
All right.
Let me let me go ahead and
Cool.
mention that. So before we
Okay.
leave this, while we're still on the screen here for those who are watching visually,
Yeah.
I did want
And
to.
I'll try to do this. I'll try to do like the sportscasters thing.
That's
So I'm
right.
trying to describe what
What
I'm seeing.
he's showing there is also, yeah, okay. The other thing that I want to mention is about motion in the sacroiliac joint, because this is a little bit challenging and confusing for some people to recognize. We mentioned this in our earlier episode too, that there's a a variety of different discussions of how much motion occurs at the sacroiliac joint and what's happening with the sacroiliac region. Let's come over here for just a moment. Let me, for those of us watching our visual indication here, I want to make a couple of notations about what we see with some of the postural challenges that people have. When you have a pelvis that tips in this direction,
anteriorly,
we refer to this as an anterior tilt of the pelvis. So the anterior superior iliac spine is tilting downwards and the backside is sort of, tilting back up. That's rotational movement there happening essentially so the pelvis gets tilted. Now, biomechanically, a lot of people misunderstand this concept and they say, well, this is happening because you're rotating this around the sacrum. But in reality, most of your anterior pelvic tilt is tilting around the axis here at the iliofemoral joint.
So it's at the hips, you're saying, and more of it's at the hips instead of at the SI
Much
joints.
more at the hips than at the SI joint. There is a slight degree of movement at the SI joint, but it's not very much movement. It's usually estimated to be somewhere of, less than about 4 degrees is kind of the average of what you hear in a lot of the literature. So it's
I'm bookmarking that as a different, I have some different numbers, but yeah, it's a small amount.
Yeah. You want to go through that, talk about what the numbers are?
When I started teaching this course, the principles course on the Ilia, I had to go do a bunch of catch up on my homework. So I went and did a survey, kind of informal survey of all the different ranges of SI joint movement that I could find. And they ranged everywhere from less than 1% to 18% in normal, 18 degrees rather, in normal people. With this is an interesting trend, and I think we also mentioned that in that earlier episode. Over the years, as measurement technologies have gotten better, the amount of movement there that's considered normal has gone down.
Yeah.
So the 4 degrees you quoted is about the average or low average of what's said, but there's really decent evidence that people can range anywhere from 1 degree all the way to 18, with like some anomalies of like 30 degrees in gymnasts and things like that.
Yeah.
But yeah, it's that's a little bit of a geeky footnote. It doesn't even really matter the number in my thinking. It's still a small amount of movement.
Yeah.
It's a small amount of movement. And we can do a lot more with our pelvis, tipping our pelvis, than the sacrum does within the pelvis.
Yeah.
Just the feeling that I'm with you on.
And one other thing that I was interested to come across when we were talking about this is that that amount of movement at the sacroiliac joint decreases with age, as we do see in many places. But there was a lot of references that I saw to people in more advanced age having it be, close to a fused joint, that they really had lost so much motion. I don't know if we want to call it lost, but it seems to be one of those things that occurs naturally with aging. There's a much lesser degree of movement occurring at the sacroiliac joint as mobility is decreased. So when
I'm curious about that.
Yeah, when you talk about the anterior tilt of the pelvis, that's the motion of the innominate bones, the pelvis, the ilium, ischium, and pubis together, rotating around the femoral head. But the tipping forward and backward of the sacrum is actually called either nutation, when the sacrum, the top or the plateau of the sacrum tips in an anterior or forward direction. That's referred to as nutation. And if it tips backwards,
that's like, sorry, that's like if I arch my back and my tailbone sticks out posteriorly, that's anterior nutation, you're saying?
Yes.
Of the sacrum?
Yeah. And then counternutation would be when it tips back in the opposite direction. So now here's where this gets a little wonky. Again, we can get a little bit geeky with this.
I'm ready.
Okay, so this is going to be more helpful for those that are watching the video, but I'll try to describe this as much as possible.
Okay. Me too.
So here comes the, let's see, do the illustration here again. If your pelvis is tilting forward and rotating in the anterior direction like this. So imagine, once again, we're talking about that anterior rotation of the pelvis where the ASIS tips forward.
Mm-hmm.
If your sacrum is relatively stable and not moving, when the pelvis
Within that bony ring.
within that bony range, within the range
Yeah.
that it has, if your pelvis tips forward and your sacrum does not necessarily go with it, you essentially get counternutation movement at the sacroiliac joint, because the pelvis rotates forward and the sacrum doesn't rotate. So it'd be the same as the sacrum tilting backwards in relation to the pelvis. The key with this is that most of the times when you're talking about anterior pelvic tilt, it's tilting more than, the 4 to 8 or degrees or whatever that is. So at a certain point, it starts rotating forward, and the binding of those ligaments are going to start pulling it forward with the whole pelvis arrangement. So it's going to start tipping forward anyway.
Can I ask you a question?
Yeah.
And if you don't want to answer it, you can ask it back to me and I'll try.
Okay.
The question is, why would we care what that's called?
What it's called?
Yeah. Why would we care that it's when you have anterior tilting of the ilium, you have counternutation of the sacrum?
Mm-hmm.
Why do we care?
I would say we care if we're trying to find some causative movements that are producing pain. So for example, if we say, like, when you tilt your pelvis forward, this really hurts. It's the same hurt you get when the sacrum tilts back. Then you could say, oh, well, that's because both of those are actually counternutating the sacrum. To me, that's kind of where it would be helpful, is to kind of precisely pick apart what's really the movement that's aggravating the discomfort.
You totally talked me into it. And if you had asked me that question back, I'd hoped I would have given that answer too. So in other words, that it helps us kind of deconstruct what might be hurting. It helps understand the movements that might be pain evocative.
Yeah.
Our client says, it hurts in this case, when I look up, when I back bend, that really hurts down there in the lower back.
Yeah.
That would be a place that we'd start to suspect.
Exactly.
No, actually, no, I said it backwards, didn't I? So like this, the counternutation would be if it hurts when I bend over to tie my shoes. That would be painful counternutation of the sacrum.
Yeah, well, it would be. So the trick kind of is, and again, we just really can't measure this very well, is how much nutation is happening or counternutation is happening, and then at a certain point you lose that motion because the whole operation tilts. So even if there's some relative counternutation with the sacrum at first, once the pelvis keeps rotating and the sacrum is, even if it's tipped backwards, the whole business is going to tip forward after a certain point.
Once we're past that 1 to 18 degrees, whatever it is, the whole pelvis ring tilts on the hip joints probably. Yeah. And so if there's pain, especially later in that cycle, I would start to wonder about hip joint rather than sacrum.
Yeah.
In any case, that's the way we use that information to start to deconstruct the painful movements to know what our target might be.
And here's why I think that is so helpful, is because there are so few methods of really effectively identifying what's causing a lot of pain problems in sacroiliac joint disorders. Many of the assessment methods are not highly precise, and so the more precision that we can get about certain types of movement things, the better we can get at kind of sort of identifying where primary problems might be.
That is such a great cue up for what I want to say later. Well, that's so great. Thank you.
Shall we hear it right now? And
the evidence turns out to bear this out, is that tests that provoke sensation tend to be a whole lot more accurate than tests where you're having to infer a problem based on position or movement.
Yeah.
So in other words, if you feel like something is out of line, maybe that's a problem, maybe you're not. And the tests that are built on position or alignment don't have a whole lot of inter-rater or intra-rater reliability. However, the tests in general that provoke a sensation on the client's part are pretty clear. Yeah. We press it, it hurts. We know now something is going on there.
Yeah.
And those tend to have a really high degree of reliability, both when I go back and check it later, but also other people checking it. And then that also tells me what I need to work with.
Mm-hmm. Yeah.
So I'm favoring those quite a bit in my my approach to this work with clients. We really are looking for sensitivity.
Yeah.
Even more than magnitude of movement in most cases.
And that is exactly what most of the literature has pointed to, is that a lot of those positional identification tests are not so accurate. And in fact, many of the pain provocation tests are not accurate by themselves. They're considered more accurate as a suite of tests that you do. And
Yes.
we can,
Okay, so could I dig into that?
yes.
In those cases that I've dug into on myself, accuracy is usually defined as correlating with an image that we can take. So that can I feel something with my hands that is accurate in the sense that it correlates with some, a radiograph or an MRI or some image that we can take to verify what was assumed to be true for palpation.
Mm-hmm.
I'm saying my pain provocation tests are nearly 100% accurate in terms of they do provoke pain.
Yeah.
So I've redefined accuracy too, as saying all I'm interested in is what provokes pain. And if I can press on something and my client says, ouch, I tend to believe them.
Yeah.
That provokes pain. 100% accurate right there.
Yeah.
And then the question is what to do. What does that mean in terms of the anatomy? I don't know. I'm going to stay agnostic on that, but I have techniques that can help work with that sensation.
Mm-hmm.
So I'm targeting the sensation of the pain itself more than, say, the misalignment or the presumed positional fault or different things like that.
Yeah. There was a wonderful little YouTube video, and maybe we'll put this in the show notes too, that's on the Physio Tutors website, which is a great educational website aimed at physical therapists and physiotherapists. And they're referring to Laslett, who's one of the authors that have talked a lot about this process of clustering tests for the sacroiliac joint. And they said, the Laslett has sort of zeroed in on 4 of those commonly used tests as being the ones that are most accurate, and those being kind of like the ones to focus the most attention on for, do we get a consistent finding from all 4 of those, or is it 2 of the 4 are positive and 2 are not, or whatever. And then also there's another article, and we'll link to this in the show notes too, from Sadek, Szadek. I'm not sure how to pronounce that. But they were making reference to a piece that came out in the International Association for the Study of Pain as a diagnostic criteria for sacroiliac joint problems. And they said, 3 key things would be necessary. One is there pain present in the sacroiliac region. And the second one was, is there a group of tests that can be selectively identified as causing problems in this cluster of tests? If 2 of the 4 are positive, then that would be considered another factor. And then the third one was selectively infiltrating the joint with an anesthetic and the pain goes away. Being the key sort of diagnostic criteria that physicians would use in identifying sacroiliac joint problems.
Yes. There's been so much work done in recent years on the accuracy question of making sure that these orthopedic tests can be replicated, can be useful information to other practitioners, say a surgeon who's going to take over after a physical therapist, things like that. That's when it gets really crucial. Either you're doing a research project and need to be precise about what you're measuring, or you're interfacing with other practitioners who are going to take your information and design treatments or interventions or surgeries based on what they're hearing from you. In those cases, anatomical accuracy is key.
Yeah.
I'm still going back to, like, on my table, if it hurts, that's all I need to know. In the sense of, like, now I have a therapeutic target.
Yeah.
And I'm not going to insist it's the joint capsule or it's the misalignment. Like I said, I'm agnostic on all that. It could be any of those. But I'm going to work with the pain phenomena on its own through gently resetting that response.
Yeah.
I could say. And
my understanding too is that might not necessarily mean localized treatment. There was a paper, I think that came out in 2021 about the stechofascial manipulation of treatment for SI joint disorders. It was talking about treatment applied pretty significant distance away from the localized pain. I think it was like, I can't remember the measurement, like 20 centimeters or something like that, away from the site of primary problems. And this is, again, emphasizing that a lot of times working on not necessarily immediately localized tissues can certainly be beneficial in addressing those kinds of complaints. Well, yeah. I mean, even like neurologically speaking, the target zone on the spinal cord for low back pain is really big. It's like a cloud more than a spot. It's not one wire going into a junction box. It's a whole field. And then in the brain, once it gets to the brain, it's also a big zone of the sensory homunculus, say, or the insular cortex, or wherever those signals are targeting.
it's like a big zone. There's lots of crossover. So it's really hard to do the exact spot
Yeah.
kind of thing,
Mhm.
except when there is a spot.
Yeah.
When there is a spot that you press and the client says, ouch, then we can work with that spot. I'm not going to presume it means anything other than that's a sensitive spot.
Mhm.
Or in the case of the Ilia and SI workshop that I'm teaching, when you push or pull on the leg or pelvis in certain directions and it evokes a little bit of that sensation, and we don't know if it's specific or general, and we don't quite know yet what's going to help, but we can trust that finding as a therapeutic piece of therapeutic information.
Yeah.
We can start to untake.
And just to kind of bang the drum on specificity and assessment once again, one of the other things that I want to say here is that one of the reasons that I like to try to zero in on trying to find as much specificity and accuracy to some of these symptoms is because a particular maneuver that provokes pain may provoke pain for quite a number of different reasons. And as an example, in the sacroiliac joint region, let's say your client is supine and you're doing some type of movement where you're bringing their thigh up towards their chest, and that's provoking pain in that region. That could be provoking pain because the hamstrings, which are connected to the sacrotuberous ligament, are pulling on the sacrum and irritating the SI joint. That may produce pain in the gluteal region and down the posterior lower extremity. That could also be producing pain because you are stretching the sciatic nerve against the sacrospinous ligament when you do that, and that can cause gluteal pain and pain down the posterior side of the leg. So
it could be causing pain from nociceptors right around the sacroiliac joint from that kind of posterior torsion of the ilia, anterior nutation of the sacrum that happens when you bring your knee to the chest.
Yeah, so
could be right there in the joint capsule. We don't know the target. We don't know the tissue at that point.
Yeah.
But I know, I don't know where you're going with this, Whitney, but I know that I can use that maneuver, the knee to the chest, to gently de-threaten that kind of movement and gently change someone's protective responses around that sensitivity, that pain.
Yeah.
And then I can also start to look in my book of orthopedic options and try other things. Maybe they've learned from you or from me, from other people, to look at some of those other possibilities, like the sciatic nerve or the hamstrings or the SI joint itself.
Exactly. And so for me, it's always kind of a process of looking for patterns. What kind of pattern is illustrated here? Is this something that looks like a pattern of neurological engagement where that, gets significantly irritated when the client lifts their head up? A lot less likelihood that we're looking at a sacroiliac joint problem from tension through the, sacrotuberous ligament if lifting the head forward is significantly aggravating that pain. That's a lot more likely to be a neurological involvement. And so, just little pieces that you can add on there that can help you kind of zero in on what you're doing is I think quite helpful in many instances.
Super helpful. Whether you're treating empirically or analytically, whether you're thinking like, here's something that I feel and the client feels, and we're going to work with that, the empirical approach that I'm describing, or analytically, where we're thinking, oh, what could be producing this and how can I start to list those out and think those through in a more linear fashion, more analytical approach. Either way, it's going to be helpful to be able to start to tease those apart. Understand them.
Yeah, excellent. So what else have you got here? We were talking about anatomy. You've got some anatomy images and things like that.
Geez. Thanks for that cue. And thanks for the discussion there too, because it's the questions of accuracy, the questions of what we do with the information. It's all contextual for me. It's like, what does, why does it matter? And I love your answers. And how am I going to use those questions there?
Yeah.
What do I want to show in terms of anatomy? I could talk about how complex this is, how many different systems have their own models of the sacroiliac pain and how complex some of them are.
Yeah.
Like, I'll just give a little preview of this one. Let me see if I can get it up on the screen properly.
Okay, we're there.
Okay, I have on the screen for listeners only, audio listeners, a handout made by a orthopedic student, an osteopathic student actually, to try to remember all the different possible torsions or rotations or shears at the SI joint. Those are all terms that refer to positional variations there that are thought to be either functional or dysfunctional. But he's got a fairly extensive table that I had to try to memorize. And when I finally found this handout, I was like, oh my God, the key, the Rosetta Stone to understand all these different left on left, right on right right margin, posterior, etc., variations that the sacrum is thought to do. So this is the way I was used to be working through these complex variations of positional changes. And then at some point, when I had to go, as I mentioned in that earlier episode, when I had to go teach it in a useful way, I realized that I'm actually working in a much simpler way on the table rather than that analytical approach. I'm actually, again, looking to find out what is interesting in terms of sensation, since that's the motivator for most clients, is like something that doesn't feel right, doesn't move right, or doesn't feel right. I want to find out exactly what I can do that reproduces that, and then start to use techniques to help either desensitize that or help it be more mobile. Now, in the case of the SI joint, since there's not much movement there anyway, it's usually not about mobilizing. Most of the mobility, you said, like comes from the hip joints.
Yeah.
I almost think about the SI joints as a funny kind of sensing shock absorber. They take up a little bit of movement, so mechanically have a small function, a little springiness there, perhaps, at least especially when you're young. But more than anything else, they're probably giving our nervous system information about loading. They're probably telling us how the load is being distributed to the two legs, or how left and right legs are moving in against each other.
Yeah.
At that joint.
Right.
So I've shifted my own thinking from position. Can we get it unrotated or upslipped or outflared or whatever? Can we undo those things to instead, how can we make sure that every dimension, every direction of movement feels okay? And that there's some sort of tolerance for the movement in every direction.
So let me ask you this question on sort of like the treatment processes that you go through and the way you think about this. Yes. Do you tend to, and maybe this isn't this kind of like is a bit individual, but would you say that you tend to move people towards a barrier of discomfort and see if you can push that barrier of discomfort farther away? Or do you try to keep those movement things within comfort zone and just sort of reinforce the comfort sensations and see if that's just
a
like
key question.
Bigger, you know?
Do I find a barrier and push against it, or do I stay way back from that and try to build capacity within that less challenging range?
Right.
It totally depends on the client's resilience, the rapport I have with them. If someone comes to me with like an SI joint that flares up and gets painful on them, I'm not going to push it.
Yeah.
It's, it's like more movement isn't going to be helpful in my thinking, probably, or at least in the past, they've had things that flared it up through more challenge.
Yeah.
So there's not about challenge. There's about calming down. And I might work well within that mid-range of small movements that just begin to feel a little funny and stop right there and have someone breathe and relax and essentially go through an autonomic or sensory new reset around that threshold.
Yeah.
And it's like, Whitney, I want to do more work with you around the hypermobility question because it's such a puzzle. I mean, in the simplest terms, a lot of manual therapies work to loosen things up.
Yeah.
And so there's a paradox when we have a situation that might be the case that things are, quote, too loose. How do we help? It isn't just to go loosen things up more.
Yeah.
It may not be as simple as just going to strengthen it more either, but I still think there's a lot we can do. And that's a puzzle I'm unpacking for myself.
It is.
Talk to you more about that.
That's a question that ironically got sort of posed to me very, very early on in my massage training, like when I was early on in school, because my mother has Ehlers-Danlos syndrome. And so,
there's a connective tissue condition where there's a lot of movement at the joints.
Excessive amount of movement at the joints, very weak connective tissues. And so a lot of the things that we were learning about, like you make everything loose, like everything was so loose already. Just like, well, what do you do? What are you trying to do? But she would have soft tissue pain. And so I'm thinking like, well, why? Why is this painful? Because it's so loose to begin with.
Because it's so too tight. Yeah.
Right. And I think probably a lot of your work on the inflammatory stuff is relevant there because there's probably a significant amount of that kind of thing going on. But this sort of gets back into a lot of these things have a whole lot more to do with nervous system responses in many instances of what we're seeing.
Well, it's the nervous system it's transmitting, generating, interpreting those nociceptive signals. In other words, the nervous system is responsible for the pain phenomenon. Yeah. So let's work right there is one of my points around that too.
Yeah.
Unless it is mobility, unless it is a sense of something, it just feels stuck. And no, it doesn't flare up. It doesn't hurt. and and I'm like totally strong and healthy, then it might be more of a mobility kind of intervention that I
Yeah.
do. How can we challenge it at the edges of where it moves and have someone find ways to allow more movement there instead?
And you brought up something earlier too, just to call attention to remembering that we are treating individuals when we do this kind of stuff, and the significant amount of mobility that you might find in a 19-year-old gymnast, and what you're going to do with them to try to work with excessive hypermobility, which you may not try to change that a whole lot, compared to the 48-year-old office worker or somebody like that, who's having some maybe more significant problems because of hypermobility and the wearing away of joints and producing arthritic changes. Those strategies may be consistently different.
They may be really different. And I don't even know that my explanations are going to be the right ones, but I know that I'm going to start with them as I'm not going to push someone that moves a lot to move more. And even when I'm playing within their mid-range to help de-threaten movement there, I'm going to be tracking how they're able to relax into it. Are they able to breathe? Are they able to stay present with the sensation? Those kinds of things.
Right.
And the same with the person that's like doesn't move at all, and it's more they're complaining about stiffness. Or I suspect, you got a really big difference left and right. There is some evidence, one study at least, Damon, 2002, that says when people have a big difference between their left and right SI stiffness, they have more pain, at least in pregnancy, which maybe applies and maybe doesn't. But let's assume it does. One of my therapeutic approaches is let's get the side that doesn't move as much to move just a little easier. And then let's see what happens. It's not my therapeutic approach. It's a really traditional one in manual therapy.
And you bring up a really interesting point there too, when you talk about the difference in movement capabilities from side to side, because a lot of people don't think about this very much. But in essence, one of the reasons that the pelvis needs that degree of mobility that it does is that in our normal gait stride, for example, as you swing your right leg forward and place it in front of you and your left leg is behind you, your pelvis, your innominates on each side are rotating in opposite directions.
Oh, and I got a visual for that.
All right, excellent. No way, good. Right here. I was going to do this with my hand. Pelvis. That's even better.
You're going to do it with your hands, but I got to try to describe it for the listeners too. You're saying that if you step forward with which leg did you say?
I said right leg forward, I think.
Okay, so your innominate are doing that a little bit. I'm exaggerating with this flexible pelvis man. I'm showing how the right innominate might tip along with the femur and the left innominate might reverse, the other way.
So those people watching the video, like look, and you can see that motion at the sacroiliac joints as well as the pubic symphysis. There's a little bit of motion occurring at each of those joints with every stride of our walking or running. So, and we don't really, we so often think about these both pathologically and in normal function as it's either both tipping forward or both tipping back, or right side tilting to left side tilting or whatever, but they need to operate in opposite movements in relation to each other during every walking stride or running.
That's right. And not so much for range of motion, but so that you have shock absorbent capacity and so that your brain knows you're walking. That's part of the sensory panoply, sensory tapestry of the walking phenomenon. Like right now in your chair, Whitney and everybody else, if you just slide your right knee forward so that you're essentially walking your right sit bone forward in your chair, that's mimicking what happens at the SI joints, left and right, during stride, that thing Whitney just described. And then just to even it out, slide the left knee forward, slide your left sit bone forward. So you're walking on your chair with your sit bones. That sensation you're feeling is what you get, similar to what you get while you're walking, and how your brain modulates walking, knows you're walking, senses what coordinates walking, all those things.
Yeah, absolutely. So,
what do you call that motion, by the way? You're calling it anterior what? When you slide, let's say you walk your sit bone forward on the right, you called it posterior tilt, did you say?
Well, it would be posterior tilt, if you're swing the lower extremity forward, and that innominate is going to sort of tilt backwards. So
Tilt is a common one. That's what Joe Mascalino calls it too. He had a cool article on that same issue, and I called him up just to talk about terminology. It's also called torsion in some models. This is called posterior torsion in the model I first trained in. It's the same thing though. It's the innominate just doing that tilting kind of idea. And then, so what do you call, by the way, if I look at now the top of the pelvis and like say the pubic symphysis is spreading, like in giving birth or something, where the innominates are moving in the horizontal plane. Do you have a name for that?
Well,
What do you
I
call that?
usually, and again, for the non-visual people, that he's pulling the pelvis, and we're looking straight down into the pelvis from the superior angle, and the two halves of the ilium are moving out away from each other or flaring out, and that's usually the term I have heard is inflare or outflare. So outflare when they tilt out, and inflare when they sort of are tipping in. So
by the way, that generally doesn't tip. It's usually taught. I learned it as like they're both quote outflaring or both quote inflaring. If they're both inflaring, they're compressing the pubic symphysis.
Yeah.
But it was a revelation to me to realize that motion happens all the time, but at the same time. So it's a contralateral inflare of one, outflare of the other.
Yeah.
And that again is walking. Or if you want to feel it in your own body, like slide your right knee forward. So you walk your right sit bone forward in your chair and then twist to the left with your spine and shoulders. So that puts essentially an outflare on your right and an inflare on your left at the SI joints. And then switch it out too. So you slide your left forward and you left knee forward, right, left sit bone forward, and twist to your right with your shoulders. That's going to do the opposite at the SI joint.
Yeah.
And that happens in walking as well.
Yeah.
Hold up and down the spine.
So while we're doing that, I want to put one other image up on the screen here for just a second, because this is another one that is somewhat confusing for folks in relation to lateral tilting.
The next plane of movement.
Yeah.
It's the next plane of movement.
So we've been talking a lot about, tilting forward, tilting backwards, but there's also the lateral tilt, which is, the tilt to one side or the other. And this happens frequently. Yeah. You want to...
Well, no, you're showing, I don't need to show, I need to explain it verbally.
Yeah.
You're showing a back view of the pelvis with a longer leg on the right side. And you're saying that side of the pelvis is taller, and you're going to tell us something about the movement that happens there at the innominate, I think.
Yeah. So we're going to assume that a person has a structurally longer right leg. So the bones of the right lower extremity, either femur or tibia or both, are measurably longer than those on the left side. And when that happens, the pelvis on the right side will, in a standing position, will sit higher. And you can sometimes do this with a visual examination or a palpatory examination and see the level of the thumbs. One's going to be higher on this side. And so
one of the bony landmarks will be farther from the floor, taller.
Exactly.
So standing.
Yeah. Yeah. Now, when the right side is higher, we call this a left lateral tilt. And this is where another place where people get a little bit confused.
Of the pelvis or of the innominate?
Well, innominate refers to, innominate again it means no name, which is kind of always thought that's interesting. So
that's another subject.
One innominate, you can have a right innominate and a left innominate, or you can talk about both of them. So in most instances, they're going to sort of tilt together. So the right one is going to be higher. It's going to cause the whole structural thing to sort of tilt more to the left side. So that's why it's called a left lateral pelvic tilt.
But I guess what I'm saying is, are you describing this now as movement at the SI joint or somewhere else at the hip joints?
Well, it's really movement. It's not so much movement as it is the way forces have to be distributed. Because when this leg is longer, the femoral head pushes up against the top margin of the acetabulum and pushes the whole thing higher. So that's just a structural positioning, a static positional movement that's going to make that higher. So high on the right side is a left lateral tilt. I always like to think about this as if the pelvis is a bowl of water, it's going to spill out to which side. And when the right side is high, it spills to the left. And so we call that a left lateral pelvic tilt. Okay.
Yep.
Now, you're smiling. You have something you want to add in there?
I'm like the cat that ate the canary. I'm just waiting.
Yeah, right.
Keep going. This is good.
Okay.
You're saying that's called the movement of that in one side of the pelvis, the innominate on the right side would be a, what did you call that again?
So that would be a left lateral tilt if the right side is higher.
Lateral tilt.
Yeah.
If the, okay, I have the opposite terminology, but go ahead. That's okay.
Well, no, explain it to me there.
I follow Diane Lee, who say on the right side, if the right sit bone gets wider and the ASIS gets narrower, that's a medial flexion, medial side flexion, she calls it.
Okay. So that would be something different, because what we're talking
Oh,
about.
that's not what you're talking about?
No,
I thought that's what
we're talking about the entire innominate is getting lifted in a superior direction.
You're talking about upslip or a slot translation at the SI joint.
Yeah, right.
Okay, gotcha.
So we talk, there's shear forces. So a sliding force at the SI joints, probably on both sides, because one side is getting lifted higher than the other side. So that's what produces unequal forces on the SI joint. This is the kind of thing that produces significant SI joint pain. You know, when you have somebody who says like, oh yeah, I just started this running regimen and I'm running, you know, on the side of the road, and, you know, the road is domed and they have one leg longer than the other. And on one side of the road, when they're running, they're just in excruciating pain in their SI joint because their long leg is on the short side of the road, and it's really exacerbating that lateral tilt force. And then they could turn around and run in the opposite direction on that side of the road, like, oh, now that feels really good, you know, because now their long leg is on the long side or on the longer side of the road. So
yes,
that's just an interesting thing with the lateral tilt.
It is. It is. Okay, so but you're not talking about tilt, you're talking about upslip, I thought.
Well, some people refer.
Never mind.
Yeah.
Never mind. Let's not get caught up in the words, because I want to talk about longer legs.
Yeah. Okay.
Okay, so longer legs are, again, you just beautifully articulated the conventional view of what a longer leg how it could manifest as symptoms. I would posit that there's a lot of other things that could explain those symptoms too, even if one leg was structurally longer than the other.
Yeah, absolutely. Yeah.
So someone could feel more comfortable running on a crowned road in one direction the other way, even just because their SI joints, they can't adapt in one way.
Mm-hmm. Yep. Yeah.
Or is more sensitized in one way,
yeah,
you could say.
Yeah, absolutely.
And with a longer bone on one side, a structurally longer leg, the sacrum is being asked to adapt asymmetrically, the SI joints, either left and right.
Yeah.
And so the most help I can give is to help them be more adaptable, have them being less sensitized to that adaptation they're doing.
Yeah. The other point that I wanted to make about this, and let me come back over here to this image here for just a second, is where we run into some problems with this is in trying to determine causative factors on that, because sometimes people will put a person on the table and, you know, pull their ankles towards them and look and say like, oh, you've got one leg longer or shorter than the other. So let's say in this instance, a person, you put them supine on the treatment table, and then you pull their ankles towards you as a practitioner, and you look, and the right side looks longer than the left side does. Okay, so we're on the treatment table, right side looks longer than the left side does. And you say to that person, oh, you've got a short left leg and a longer right leg. Because, and then what you do is say, well, you need to put a heel lift in your shoe so that can make those lengths equal. But what might be occurring with that individual is not that the right leg is structurally longer, but back over here, and let's do this really quick from our little drawing, our quadratus lumborum over on this side, on the left side, is hypertonic and pulling that ilium in a superior direction, causing a lateral tilt. And when you put that person supine on the treatment table and look at their legs, this left side is going to look shorter than the right side. And if you put a heel lift under that short side, when this is a functional leg length discrepancy as opposed to a structural one, you actually exacerbate or make that problem worse. And that could, aggravate somebody's SI joint pain significantly.
I didn't even let you make your point before I was giving alternatives. So that, your point is there that it could be a functionally shorter leg rather than a structurally shorter one.
Yeah.
The explanation you gave of quadratus tight on the shorter side would be right along with a biomechanical model that has tissue tightness as the causative factor for those differences. And of course, we got to assume that people using orthotics or prescribing them for sure are taking these things into account, and their models are much more complex than the one we're describing here. From another point of view, there are many things other than the QL say. Someone might go say, let me go work now with the QL on that side to see if I can get that hip to drop. I've heard those kind of treatment approaches posited as well. And we actually do some of that kind of thing in our scoliosis work as well.
Yeah.
There's so many things that could be responsible for one hip showing higher or a functional leg length discrepancy.
Yeah.
And I just gotta say, I do go for movement more than position, even in that case.
Yeah.
I say, can the left leg lengthen as much as the right leg? And then if it can't lengthen, what can I do to help it be willing to lengthen more comfortably?
Yeah.
And it might include QL, it might include different things.
Yeah.
It include who knows what, transversus, latissimus, gluteus, things that they do at the knee. What I have to ask before I can pull on their leg. There's lots of factors there that could be a part of that left leg's willingness to lengthen.
Yeah.
Example.
And let's just highlight too, when you talk about the left leg lengthening, we're not actually lengthening a person's leg, just so everybody understands what we're talking about here.
Lengthening is a movement more than a static situation,
Right.
that condition.
Yeah.
Yeah. Being willing to get longer.
Yeah. They're not the rubber stretchy Gumbies that we're going to lengthen their
moment,
limbs.
right. Exactly.
Yeah.
Exactly. But no, this is an example. Not only are positions and bony terminologies complicated, but we start to talk about the pelvis in language that combines position and movements.
Yeah.
It isn't always clear. Like a tilted pelvis is a movement terminology that describes a position.
Yeah.
And so that's some of the confusion you and I are just running into as well. But it's so important to tease those apart if you want to get really methodical about it. And it does inform our treatment approaches too, that if I assume that high left hip is being pulled up by a tight QL, that's a different thing than thinking, okay, so it can't drop in walking or whatever.
Yeah.
And then how can I help it drop? And there might be lots of things that could help it be willing to drop.
Yeah. Yeah. So where do we go from here? You got other things?
Where do we go from here?
Yeah.
Well, there's that last plane. I just should do one more thing. We talked about like the, what I call torsion, the anterior posterior tilt. We talked about nutation of the sacrum. We talked about in-flare, out-flare. We didn't talk about, I mentioned the name lateral side bending, of the pelvis. You said the whole pelvis could go up and down with a leg length. But if you scoot yourself over, listeners and co-host, to the edge of your chair, if your arms allow that, you can get like one sit bone off the chair, or you can turn sideways in your chair. So you hang one sit bone off your chair and the other's on that. That's putting that kind of force through your pelvis in the frontal plane, the coronal plane. Like one anomaly is trying to outflare, could say, and it's trying to inflare. And that's such an important, do it on the other side too. So let the other sit bone hang off. This is great, by the way. These self-care possibilities were inspired. I learned them from the work of Richard DonTigny, who's a physical therapist who specializes in SI joint stuff. And then I recently used a couple of his, come back up on your chair if you're not there, used a couple of his illustrations and articles in Massage and Bodywork, and went and found him in an assisted living facility in Bozeman, Montana, where he was so delighted to hear from someone still reading his work. And we had a fun time talking about these illustrations and the ideas that he used, which you can see in those articles. But he was a pioneer in really using these kind of self-care ideas that I just showed you, hanging your things off the chair or bringing your knee to your chest, like you described, to help people manage their own SI joint discomfort and pain.
Right.
But early on, he wasn't saying, let's mobilize it. He's saying, let's make sure that movement's comfortable. Do it both directions, he would say, do both sides.
Yeah.
It wasn't like correct the position. It was like more like, let's mobilize it and help it be more comfortable.
Yeah. Yeah. I think I remember coming across some of his work and writings too, that were in Leeming's Movement Stability and is it Movement Stability and Low Back Pain? Is that the title of that book? Is that?
Yeah, we can look that up. No, but it's right. Leeming, went and dialed it down a lot more precisely.
Yeah.
But DonTigny was one of those pioneers who was saying, here's a bunch of stuff that just really seems to help.
Yeah.
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 Well, that's pretty much, I think, our high points, huh? We've probably lost the right percentage of our audience by now.
I think so, probably. Yeah.
So congratulations to the survivors who made it this far.
Yeah.
That's great.
Yeah. But as you can see, lots and lots of things to dig into, and until you're going to dig into that in your upcoming online class, again, your principles series class. I'll let you plug that one more time here.
That?
All right.
Well, I'm going to plug it because I'm going to, like we mentioned before we went on the air, I'm going to invite you to come give a little guest spot there. And we might even bring out this podcast as some as an example and like, maybe cook it down even
Yeah.
shorter version, because that Ilia and SI joints class is live online. There's 4 lectures. They happen every 2 weeks. You can be there live and ask questions. You can go to the small groups where we discuss them or not. Those are optional. You can actually take a client and turn on your camera and show us working on them, and we will coach you individually as a part of that class or not. That's optional too. But the whole price is pretty affordable, and it's based around those 4 live online lectures that happen every 2 weeks, starting October 5th, 2022, or later by recording. The free intro is on September 28th, optional, but it'll give you a sense of what the class is like. It's one of our principles courses where we're really trying to take people to the next step in their work and understanding of the principles behind what they're doing and how we use that in our approach as well.
Yeah. Awesome. Sounds like a
It'll
great
link for
thing.
that in the show notes.
Yeah.
Advancedtrainings.com if you want to go look it up now, but otherwise check out the show notes. Should I go ahead with the closing sponsor?
Yes, I think that's probably we'll do a wrap up here for today. I think that was a great deep dive into these things here.
Great.
So who's our
Great.
sponsor wrapping up?
Our closing sponsor is Handspring Publishing, who's been with us from the beginning, and really from the beginning of my publishing career, because when I was looking for a publisher for a book, I was fortunate enough to have had 2 offers, one from a large international media conglomerate and the other from Handspring, which at that time was just a small publisher run by 4 people out of Scotland who loved great books and loved our field. And to this day, I'm glad I chose to go with them. Handspring is not only did they help me make the books I wanted to share with you, the Advanced Myofascial Technique series, but their catalog has emerged and persisted as one of the leading collections of professional level books written especially for body workers, movement teachers, and all professionals who use movement or touch to help patients achieve wellness.
And note that Handspring was recently joined with Jessica Kingsley Publishers' Integrative Health Singing Dragon imprint, where their amazing impact continues. So you can head on over to their website at handspringpublishing.com to check on their list of titles, and be sure to use the code TTP at checkout for a discount. So thank you again very much, Handspring. And we would like to say a thank you to all of our sponsors, and of course to you, our listeners, as well. You can stop by our sites for show notes, hand out transcripts there, any extras. You can find that stuff.
Video.
Yes, a video on this one. True. You can find this one over at academyofclinicalmassage.com. And Til, where can people find that for you?
Advanced-trainings.com is my site where we'll put this episode's video and audio and transcript. If there are questions or things you want to hear us talk about on the podcast, just email us at info@thethinkingpractitioner.com or look for us on social media. I'm at Til Luchau on all forms of social media. Where are you, Whitney?
Most days I can be found on social media under my name as well. Also at Whitlow over on Twitter. So some form of that can help find me. You can rate us on Apple Podcasts, as it does help other people find the show. That is quite important, actually. And you can hear us on Spotify, Stitcher, Google Podcasts, or wherever else you happen to listen. Please do share the word, tell a friend, and thank you again so much for taking some time out to listen to us. We hope we maybe enriched your sacroiliac understanding a little bit, and you can help some other folks out there who are in need of your help as well.
Indeed. Thanks for hanging with me, Whitney.
Great to be with you once again, sir, and we'll be back again in just a couple weeks on another deep dive into some fascinating, enriching topic there.